systemic anastomosis, and the spleen. Pancreas is an elongated accessory digestive gland. It's a secondary retroperitoneal organ, transversally across the posterior abdominal wall. Lies posterior to the stomach between the duodenum on the right and the spleen on the left. We remember that it forms the posterior wall of omental bursa. So it forms the bed for the stomach. The transverse mesocolon attaches to its inferior margin. We can see it now. The root of the transverse mesocolon is removed for show us that here is the place where it's attached the transverse mesocolon. Transverse mesocolon also forms the posterior wall of the omental bursa, yes, with the transverse colon. Pancreas has four parts: the head, neck, body, and tail. Neck of the pancreas overlies the first and the second lumbar vertebrae in the transpyloric plane. You remember, I've told you that this transpyloric plane is very important because at the level of the L2, we have a lot of structures, yes, which start at this level. Its head is to right and inferior to this transpyloric plane. The body of the pancreas and the tail of the pancreas are to the left and superior to the transpyloric plane. Pancreas lies deep in the abdominal cavity, so it's very difficult to palpate this organ because we know it is behind the stomach, yes, and lies on the posterior wall of the abdominal cavity. Pancreas has two functions. First, it's an exocrine secretion, so it's from the pancreatic juice from the acinar cells. Here we can see these acinar cells, this pancreatic juice enters the duodenum through the main and accessory pancreatic ducts. And the endocrine secretion, which is formed by the islets, Langerhans islets. So here are produced the glucagon and insulin, very important hormones from the pancreatic islets, and that enter to the blood. So exocrine secretion from the acinar cells and the endocrine secretion, there are hormones. And because the levels of the hormones are changed in our blood, yes, so it should be, it should go into the blood, yes, faster, yes, than through this ducts. Head of the pancreas is expanded part, is embraced by the C-shaped curve of the duodenum to the right of the superior mesenteric vessels. Here we can see the superior mesenteric artery and vein. The head of the pancreas firmly attached to the medial aspect of the descending and horizontal part of duodenum. Head of the pancreas rests posteriorly on the inferior vena cava, right renal artery and vein, and left renal vein, which passes on the left side. The common bile duct, here, the green color, lies in a groove on the posterior superior surface of the head of the pancreas. So look, this common bile duct firstly crosses posteriorly the superior part of the duodenum, and next it passes in the groove between the descending part of duodenum and between the head of pancreas. The uncinate process is a projection from the inferior part of the head of the pancreas. So here we can see this uncinate process. It extends medially to the left and extends posterior to the superior mesenteric artery. Look, here now the superior mesenteric artery is cut, yes, for show us the uncinate process. The part of the head of the pancreas. The neck of the pancreas is short. It overlies the superior mesenteric vessels, which form a groove in its posterior aspect. Anterior surface of the neck of the pancreas is covered with the peritoneum and is adjacent to the pylorus of the stomach. Posterior wall of the neck of the pancreas, posteriorly, is located the superior mesenteric vein, which joins with the splenic vein. A little bit we can see it, yes, but we know that it passes below the splenic artery, so we can see it on the posterior surface, posteriorly to the body of the pancreas. So this place is very important because here is the union, is the junction of the splenic vein with the superior mesenteric vein. And today we will see that the neck of the pancreas is removed for showing us this junction between the superior mesenteric vein and splenic vein. And they form the portal vein. The body of pancreas continues from the neck of the pancreas and lies to the left of the superior mesenteric vessels, so the superior mesenteric artery and vein. Body of the pancreas passes anteriorly to the abdominal aorta and the L2 vertebra. Anterior surface of the body of the pancreas is covered with the peritoneum and forms part of the stomach bed. Now the stomach is removed for show us this body of the pancreas. Posterior surface is devoid of the peritoneum as is in contact with the abdominal aorta. Look, the superior mesenteric artery, the left suprarenal gland here is visible, left kidney, and the renal vessels which enter or leave a kidney, so the left renal vein and left renal artery. The tail of the pancreas lies anterior to the left kidney. And this is the tail of the pancreas. It's closely related to the hilum of the spleen and the left colic flexure. Is relatively mobile and passes between the layers of the splenorenal ligament. The tip of the tail is usually blunted and turned superiorly. The main pancreatic duct or duct of Wirsung, yes, in the clinical language is common use this name, begins in the tail of the pancreas and runs through the parenchyma of the gland to the head. In the head, turns inferiorly and is related to the common bile duct. Unites with the common bile duct to form the hepatopancreatic ampulla. The sphincter of main pancreatic duct, the sphincter of bile duct, and the sphincter of hepatopancreatic ampulla, which is called the sphincter of Oddi, are smooth muscle sphincters that control the flow of bile and pancreatic juice into descending part of duodenum. We know that the parasympathetic fibers, they relax such sphincters, yes, and the pancreatic juice can flow to the descending part of the duodenum. Later we will, one more time, we will see such sphincters. The next duct is the accessory pancreatic duct, which is very also often use the name, the duct of Santorini. But Santorini not from the name of the island, very beautiful island, Greek island, but from the anatomical, from famous anatomist. But it's better to remember, yes,
a few years ago, there was such question in the golden scapula competition. Yes, the duct of Santorini, they used it. Yes, so we need to know. Drains the uncinate process and the inferior part of the head of the pancreas. Opens into the duodenum at the summit of the minor duodenal papilla. Usually communicates with the main pancreatic duct, but in some cases is greater, this accessory pancreatic duct, and the two are it happens that sometimes it carries most of the pancreatic juice. So, one more time, let's see. Yes, this is the minor duodenal papilla. Here enters the accessory pancreatic duct. It's impossible to see this minor duodenal papilla in our specimens. And the major, you can try, but it's extremely difficult. The body and tail of the pancreas are supplied by the splenic artery, which sends 10 branches to the pancreas. A head of pancreas is supplied by the superior and inferior pancreatico-duodenal arteries. We know that they have the different origin, yes? So, the superior pancreatico-duodenal artery is a branch from the gastroduodenal artery. The inferior pancreatico-duodenal artery is a branch from the superior mesenteric artery. Superior and inferior pancreatico-duodenal arteries, they give the anterior and posterior branches, and they join together and they form an arches, yes, along the head of the pancreas anteriorly and posteriorly. The veins of pancreas are tributaries of the splenic and the superior mesenteric parts of the portal vein. So look, now the neck of the pancreas is removed for showing us the union of the splenic vein and the superior mesenteric vein. And next is formed the portal vein. Very important, today we will talk about it. Most of veins, they empty into the splenic vein, which passes posteriorly to the pancreas. Lymphatic vessels of the pancreas follow the blood vessels. Most of them end in the pancreatico-splenic lymph nodes that lie along the splenic artery. Some of them end in the pyloric lymph nodes, which are located at the lesser, at the pylorus, close to the pylorus. And efferent vessels from the pancreatico-splenic and pyloric lymph nodes drain to the celiac lymph nodes, which are located around the celiac plexus, or to the hepatic lymph nodes, or to the superior mesenteric lymph nodes. Generally, next are formed the intestinal trunks, lymphatic trunks, and next is formed the chyle cistern. The nerves of pancreas are derived from the vagus nerve and thoracic splanchnic nerves, which pass through the diaphragm. The fibers pass along the arteries from the celiac plexus and the superior mesenteric plexus, so around the superior mesenteric artery. To the pancreatic acinar cells and islets, passing parenchymal, so the sympathetic and parasympathetic fibers, and to the vasa, passing vasomotor, so sympathetic fibers, because we need to fast response, yes, so the vasomotors or sympathetic, yes, and for example, the hormones which are produced by the islets, the pancreatic islets, when we need the insulin after the big meal, yes, it should be the fast response. Or if we have the lower level, yes, of the glucose in our blood stream, so the glucagon, yes, there is a response of it. The next organ in our body is the liver. Liver is the largest gland in the body. Weighs approximately 1,500 grams and accounts for approximately 1/4 of adult body weight. Lies inferior to the diaphragm, which separates it from the pleura, lungs, pericardium, and heart. Liver has many metabolic activities, stores glycogen and secretes bile. We can't live without liver. We can live without the spleen. We can live without stomach, without kidney. Yes, because it's possible, yes, to prolong the life of the patient. Without liver, we can't live. It's our big factory, and if somebody has destroyed liver, he needs the transplantation, because without it, yes, without the activity of liver, the patient, a patient can die. Yes, so we can't live with it. Without, also we can live without the large intestine. Is possible. Yes, I have my friend lives about 10 years without the large intestine and the part of the ileum. So, liver lies mainly in the right upper quadrant and is hidden and protected by the thoracic cage and the diaphragm. Liver lies deep to the ribs 7 through 11 on the right side and crosses the midline toward to the left nipple. Liver occupies most of the right hypochondriac region, epigastric region, and extends into the left hypochondriac region. So 3 regions occupies a liver. Look, here we can see the inferior border, which is normal when the organ is in normal size. It's difficult to palpate because it's hidden, it's protected by the costal arch. Liver has 2 surfaces: the diaphragmatic surface, anterior, superior, and some posterior, and the visceral surface, posterior-inferior. Surfaces are separated anteriorly by its sharp inferior border. So we can see here and here. Is covered by the subperitoneal fibrous capsule. This capsule is called the Glisson's capsule. Today in our specimens, in one cadaver, you can find also the falciform ligament. So please look in this best cadaver where we have where they are present the mesocolons, the transverse, sigmoid, and mesentery. So this the new one. Yes. So there is visible the falciform ligament. The diaphragmatic surface of the liver is smooth and dome-shaped. Is largely separated from the diaphragm by the subphrenic recesses between the anterior part of liver and the diaphragm. Is covered with the visceral peritoneum, except posteriorly in the bare area of the liver. Soon we will see it. The hepatorenal recess, or the Morrison's pouch, is a deep recess on the right side which extends superiorly between the liver, the right kidney, and the right suprarenal gland posteriorly. Fluid from the omental bursa drains into this hepatorenal or Morrison's pouch. This hepatorenal recess communicates anteriorly with the right subphrenic recess. So now let's talk about the bare area of the liver. So this is the place where the liver is not covered with visceral peritoneum. Normally, we can say that liver is an intraperitoneal organ, yes, but there are some places where the liver is not covered with the peritoneum. And on the diaphragmatic surface, this place is in the bare area. So liver lies in the contact with diaphragm. Look, now the liver in this picture is removed, and we can see that here is a little bit peritoneum, but this place shows us the diaphragm. The bare area of the liver is demarcated by the reflection of the peritoneum from the diaphragm to it as the anterior, the upper, and the posterior, the lower layers of the coronary ligament. This is the coronary ligament, which forms on the left side and the right side the triangular ligaments. So they are in the angles. In the angles of the bare area, they are formed from the coronary ligament, the left triangular ligament, and the right triangular ligament. On the visceral surface of the liver, we can find the right and left sagittal fissures. The visceral surface of liver is covered with the visceral peritoneum, but except at the bed of the gallbladder and the porta hepatis. So, but now we are talking about the visceral surface. There was the diaphragmatic surface, the bare area, and now the visceral surface. The visceral surface of the liver is related to the stomach, to the superior part of duodenum, lesser omentum, gallbladder, right colic flexure, the right transverse colon, the right kidney, and right suprarenal gland. So look, a lot of structures, yes, when we will see the cadaver, we will look into the structures which are related to such visceral surface. So stomach, the superior part of duodenum, lesser omentum, gallbladder, right colic flexure, right transverse, right part should be, yes, because we don't have the right and left transverse colon. So I'm so sorry, it should be the right part of transverse colon, the right kidney, and the right suprarenal gland. Some part of esophagus, this abdominal part, is also related to the liver. In the liver, we can find the functional parts. There are segmentation of the liver, which are based on the principal divisions of the hepatic artery proper, which enters the porta hepatis, the portal vein, which leaves a liver, and the accompanying hepatic ducts. Of course, I wouldn't expect from you the knowledge of the segments of the liver, but now you need to know that there are present some segmentation, some functional parts of the liver, because the surgeons, yes, can remove some segments, some parts of the liver. Yes. When there are present some abscesses, some metastases, so it's possible to remove, yes, and next the liver, the other parts can work. Yes. So we can remove only, there is a possibility only to removing some part of liver. The functional parts of the liver has functionally independent right and left parts. So the portal lobes, the right, or we can call it also the right and left liver, yes, that are approximately equal in size. On the visceral surface, the right liver is demarcated from the left liver by the gallbladder fossa inferiorly and the fossa for the inferior vena cava superiorly. Each part has its own blood supply from the hepatic artery and the portal vein and its own venous and biliary drainage. So it's enough to know that there are some possibilities to removing some functional parts of the liver. But for anatomy, we need this division, the anatomical, so the non-functional lobes of the liver. And the best are present on the visceral part, because surface, because on the diaphragmatic surface it's impossible to see all of lobes, because we can see only the right and left lobe, which are separated by the falciform ligament. On the visceral surface we can see the right lobe of liver, left lobe, quadrate lobe, and the caudate lobe. Left lobe of the liver is separated from the caudate and quadrate lobes on the visceral surface by the fissure for the round ligament of liver and the fissure for the ligamentum venosum. And I've told you that on the diaphragmatic surface the left lobe is separated by the attachment of the falciform ligament. So the fissure for the round ligament and the fissure for the ligamentum venosum, they both of them, they form the left sagittal fissure. In Polish books there are called the left sagittal sulcus or groove. So never mind. The round ligament of liver is a fibrous remnant of the umbilical vein. So from the, you remember, I'm sure, that in the fetus was the umbilical vein which passes from the placenta to the fetus, yes? And the next, this umbilical vein is occluded and forms the round ligament of liver. In the fetus, it carried the well-oxygenated and nutrition-rich blood, so it's a very important structure, yes, in the fetus. And the next structure, which is very important for the ultrasonographers, which take care about mother and her baby, yes, especially her fetus, because the ligamentum venosum in the fetus forms the ductus venosus. Yes, and such ductus venosus is very important structure because it joins the umbilical vein with the inferior vena cava. So this is fast way with the well oxygenated blood and the nutrition rich blood, yes, from the mother, yes, look, it's a very fast way through the umbilical vein, through the ductus venosus, and next is joined to the inferior vena cava, right atrium, yes, and to the whole circulation for the fetus. So it's a very fast way, because it's possible that some amount of blood can pass through the umbilical vein, but next there is the junction with the portal vein. So to the portal vein, to the sinusoids of the liver, to the cells of the liver, and next through the hepatic veins, and next to the inferior vena cava. So this is the longer way. The vessels for the liver are from the two sources. So the portal vein, which is 70%, and the proper hepatic artery or hepatic artery proper, you can choose, yes, the 30%. The portal vein drains venous blood from the gastrointestinal tract, spleen, pancreas, and gallbladder to the sinusoids of the liver. So generally we can say that it drains blood from the unpaired, the single organs, that the small intestine, the large intestine, there are single, yes, the unpaired organs, or the part of large intestine, the rectum. From sinusoids of the liver, the blood is conveyed to the systemic venous system by the hepatic veins that drain directly to the inferior vena cava. Look, so now we can see a little bit the inferior vena cava, yes, and there posteriorly we will see it perfect in our specimens that the hepatic veins, they drain into the inferior vena cava. The portal vein is formed by the union of the superior mesenteric and the splenic vein posterior to the neck of the pancreas. And portal vein achieves the porta hepatis. Portal vein collects a poorly oxygenated blood, but it's nutrition-rich blood from the abdominal part of the gastrointestinal tract. It's the main channel of the portal venous system. Branches of the portal vein and in expanded capillaries, the venous sinusoids of the liver. So, look, here we have some strange network, because, look, from the, for example, from the some part of intestine, yes, here we have the capillaries, yes, the venous capillaries. And next, there are formed the bigger vessels, yes, and the biggest the portal vein, and next the portal vein divides, yes, and forms the sinusoids. And next, there are formed the capillaries of the liver. So, normally, there is that the artery splits, divides into the capillaries, the arterial capillaries, and next, the venous capillaries form the bigger veins. Yes, it's normal. But here is some strange network from the vein to the vein. Yes. The similar strange network, but it will be the arterial, it will be present, and the next, so when we will talk about the kidney, yes, so it will be present in the glomerulus. So remember, because it's interesting, yes, that from the veins to the veins. The inferior vena cava is the largest vein in the body. It returns poorly oxygenated but non-portal blood from the lower limbs, most of the back, the abdominal walls, and the abdominopelvic viscera. But abdominopelvic viscera, we are thinking about these haired organs, yes, like a kidney, like a suprarenal glands, yes, or from organs from the pelvic cavity. Besides, of course, the superior part of rectum. Inferior vena cava begins anterior to the L1 vertebra by the union of the common iliac veins. The union of the inferior vena cava occurs approximately 2.5 centimeters to the right of the median plane, inferior to the bifurcation of the abdominal aorta. Look, we know that abdominal aorta ends at the level of the L4, L3, L4. Yes, it depends on book. Yes, and on, of course, of the body of people. Yes, so more or less L3, L4. Here is the bifurcation of the abdominal aorta, and look that abdominal aorta is slightly to the left. Yes, the inferior vena cava, yes, is present on the right side. So for the pregnant women, yes, it's better to lie on the left side than to the right side, because when she lies at the right side, yes, it presses the flat inferior vena cava, yes, the organs, yes, they press it, yes. Abdominal aorta is a strange vessel, yes. So it has a thick wall, yes, so it couldn't be pressed, yes. But inferior vena cava is a flat vessel, yes. So there is a possibility to press it, yes, and there is a problem with returning the blood from the upper limb and from the abdominal cavity. Inferior vena cava ascends on the right side of the bodies of the L3 through L5 vertebrae and on the right psoas major muscle to the right of the abdominal aorta, I've told you. Leaves the abdomen by the passing through the caval foramen, yes, in the central tendon, you remember, and enters the thorax and enters the right atrium. Almost all blood from the digestive tract is collected by the portal vein, now it's not present, and passes through the hepatic veins to the inferior vena cava. So, when we can say, in general, yes, we have two ways about the collection of the blood from the abdominal cavity. One of them, it's through the inferior vena cava. The second one, it's a portal venous system. But from such portal venous system, next, the blood leaves a liver, yes, and drains through the hepatic veins to the inferior vena cava, because inferior vena cava need to collect all of blood, yes, to the right atrium. There is no some other branches. Oh, of course, somebody can say that the ascending lumbar vein, yes, which forms the azygos or hemiazygos, yes, or some other branches. But normally, yes, the most all blood, yes, is collected by the inferior vena cava through possibilities of portal venous system or directly through the inferior vena cava. The portal venous system communicates with the systemic. Systemic, it means that this is the inferior vena cava or superior vena cava. So, azygos system, yes. So the portal venous system through the portal vein, yes, communicates with the systemic venous system through the esophageal veins, rectal veins, inferior and middle. Why superior? Because superior belongs to the portal venous system, yes? Superficial epigastric veins, which passes superficially, and retroperitoneal veins. So let's look to the junction. So, the portal venous system communicates with the systemic venous system through the esophageal veins to the azygos vein, through the left gastric vein. So look, left gastric vein which passes with the left gastric artery, yes? And left gastric vein, it's only one, remember, because it's unpaired, single vessel. It sends branches which are joined with the esophageal veins. And next, the esophageal veins, the blood from them is collected by the hemiazygos, accessory hemiazygos, and next to the azygos, and azygos to the superior vena cava. It's the most important junction between the portal venous system and the systemic venous system. The portal venous system also communicates with the systemic venous system through the rectal veins, inferior and middle. Such inferior and middle rectal veins, let's say in general, because the inferior, it will be from the pudendal, internal pudendal, yes, and the middle, it could be a branch from the vesicle, but generally the blood passes to the internal iliac vein. And look, internal iliac vein, common iliac vein, and next inferior vena cava. So we are in the systemic venous system. Or the portal venous system could be, it communicates with the systemic venous system through the paraumbilical veins, which are located around the umbilicus. They join with the superficial epigastric veins. Such superficial epigastric veins, yes, they could be connected with the branches of the lateral thoracic vein, and next the axillary vein, subclavian vein, subclavian, the brachiocephalic vein, and the superior vena cava. So we achieve the systemic venous system. Or the fourth, the portal venous system communicates with the systemic venous system through the twigs of the colic veins, which anastomose with the retroperitoneal veins. Which vein could be the retroperitoneal? For example, the lumbar vein, which drains into the inferior vena cava. So, the twigs of the colic veins, yes, colic veins, we know that normally, yes, the blood is collected through the inferior mesenteric vein or superior mesenteric vein, and next to the portal vein, yes. But the twigs of such veins could be connected with the retroperitoneal veins, so which are outside of the peritoneal cavity. For example, the lumbar veins, which drain to the inferior vena cava, yes, so through the systemic venous system. Why we are talking about the portal systemic anastomosis? You need to understand it now, yes, in the anatomy course, because later maybe nobody will find a time, yes, for explaining it, yes. So now you need to understand it, yes, why we are talking about such portal systemic anastomosis. They are very important clinically in the advent of an intrahepatic or extrahepatic portal venous block. because of liver disease or physical pressure the tumor. So it could be possible that here is present some tumor which presses the portal vein, yes, and the blood can flow to the liver, yes, or there is inside present some thrombus, yes, which also blocks the blood in the portal vein. Or there is some disease, yes, the cirrhosis hepatis, yes, or after drinking a lot of alcohol. So it happens that normally the blood can't flow through the liver because the liver is destroyed. The sinusoids, yes, so there is a big problem. So blood from the gastrointestinal tract can still reach the right atrium, so to the heart, yes, through the several alternate roads. So blood can flow in a reverse direction to the inferior vena cava, or superior, yes, through the zygotes, because the portal vein and its tributaries have no valves. So what it means? That the blood normally should go through the liver, but if it is present a blockage, can go to the alternate roads. You know this picture because I've shown it, yes, at the second lecture. So where there is present some portal hypertension because of some diseases, yes, of the portal vein or liver, the blood the blood needs to go to the esophageal veins, but esophageal veins normally there are not a big vessels, so they now when there is a present portal hypertension, yes, so they are varicose, they extend because they need to admit more blood than there is possible, and they become the varicose, they are distended. So produce enlarged varicose veins and the sites of anastomosis between the portal and systemic veins. The veins may become so dilated that their walls rupture, yes, so we have a hemorrhage. The hemorrhage from the esophageal varices. It's a huge hemorrhage. In my life, I saw 2 hemorrhages from the esophageal varices. So one of 2 patients died because he was older, so we couldn't help him. But the young boy, fortunately, we helped him. So but the hemorrhage. Maybe in your life you will see the huge hemorrhage from the esophageal varices. When we didn't help, when we couldn't help such patient where he has a hemorrhage from this varicose veins, from the ruptured veins, in the 90% it leads to the death of patient. So it's very dangerous hemorrhage. The next junction of when we have blockage in the portal venous system, it's presence of the head of medusa. So the paraumbilical veins may become varicose and look somewhat like small snakes radiating under the skin around the umbilicus. Look, this is the mosaics from the island Kos. I took a picture for students because I wanted to show it, yes, during my lecture. So it's a head of Medusa, the caput Medusa. Medusa was in the Greek mythology some creature, and when somebody looked at her, he becomes a stone. So maybe you know this Greek mythology. So the Medusa, and around her head, yes, it's because it was creature, yes. So a head, yes, were snakes. So it's a similar like in the portal hypertension, where we have the head of Medusa, yes, the caput Medusa. So the veins, the paraumbilical veins, are distended, yes, and form it. Hemorrhoids are not typically related to the portal hypertension, but can occur. The doctors who are the specialists in such problem with the hemorrhoids of the anal canal, of the anus, they say that they are not typically for the portal hypertension, but it could be present, yes. Look, because here we have the posterior surface of the anal canal and the rectum, anal canal and rectum. So here we can see the superior rectal vein, and the middle, and the inferior, yes. And where is the blockage in the portal venous system? So the blood can't return through the superior rectal vein, and the blood runs through this middle and inferior, yes, and they are also distended and form the hemorrhoids. But don't think that when the patient will be admitted, but by you, yes, all of them have will have a problem with the portal hypertension, because it depends on other circumstances, not about the portal hypertension. Most of them, please remember, I need to emphasize it, that with the where is the problem with the portal hypertension, there will be the cirrhosis, the distended veins in the esophagus, yeah, and the distended paraumbilical veins, so the head of Medusa. There are both of them. The hepatic artery carries well-oxygenated blood from the abdominal aorta. Hepatic artery is divided into the common hepatic artery from the celiac trunk directly to the origin of the gastroduodenal artery, and the hepatic artery proper from the origin of the gastroduodenal artery to its bifurcation into the right and left hepatic arteries. But in some books you can find that the hepatic artery proper could be divided not into the right and left hepatic arteries, but into the right and left branches, yes, of the hepatic artery proper. So it happens that in some books there is written, yes, that there are the branches of the arteries, but in the more there are present the arteries. So right and left. Within each part, the primary branchings of the portal vein and hepatic artery are consistent enough to form the vascular segments. A horizontal plane through the right lobe and the lateral division of the left lobe plus the caudate lobe divides the liver into the 8 vascular segments, and I've told you. Between the segments are the intersegmental veins. So here there are present the sinusoids, yes, so this capillaries, yes, of the portal vein. Look, on the visceral surface of the liver, I've told you that there is present the left sagittal fissure, and here soon we will talk about it. Yes, the right sagittal fissure. Yes, between them there are present the porta hepatis or hepatic portal. The porta hepatis is a transverse fissure on the visceral surface between the caudate, quadrate lobes, where the vessels and ducts enter or leave the liver. So the porta hepatis gives passage to the portal vein, and look that the portal vein is the most posterior structure in the porta hepatis. So if you don't want to make a mistake, yes, so remember that the portal vein is the most posterior structure in the porta hepatis. Hepatic artery proper will be slightly on the right side. Of course, we wouldn't see the hepatic nerve plexus, the hepatic ducts. So it depends what we will see in the porta hepatis, because sometimes we can see the right and left hepatic duct, and next it forms the common hepatic duct. But generally, it's located. There are located the hepatic ducts on the right side, and they are slightly to the right and anteriorly, and the lymphatic vessels, of course. The lesser omentum passes from the liver to the lesser curvature of the stomach and the first 2 centimeters of the superior part of duodenum, so the ampulla of duodenum. Hepatoduodenal ligament is a thick free edge of the lesser omentum and closes the portal vein, the common bile duct, the hepatic artery proper, a few lymph nodes, lymphatic vessels, and the hepatic plexus of nerves. Hepatogastric ligament extends from between the groove for the ligamentum venosum of the liver, or fissure, yes, and the lesser curvature of stomach. Lymphatic vessels of liver drain to the hepatic lymph nodes scattered along the hepatic vessels, and ducts in the lesser omentum and into the celiac lymph nodes. Drain also into the phrenic lymph nodes or join deep lymphatics that have accompanied the hepatic veins, converging on the inferior vena cava and pass through the diaphragm and into the posterior mediastinal lymph nodes and next to the thoracic duct. So let's talk about the lymph drainage of the liver. So from the posterior surface of the left lobe, the lymph passes toward the esophageal hiatus, to the diaphragm, to the end in the left gastric lymph nodes. Left gastric lymph nodes, we remember, look, they are present with this green color, so at the lesser curvature. From the anterior central diaphragmatic surface along the falciform ligament, so falciform ligament which separates the right and left lobe of liver, to the parasternal lymph nodes, or along the round ligament of liver to the umbilicus and lymphatics of the anterior abdominal wall. So generally the lymph drainage of the liver, the lymph can pass into the different direction. The nerves of liver derived from the hepatic nerve plexus, the largest derivative of the celiac plexus, so which is around the celiac trunk. The nerves of the liver accompany the branches of the hepatic artery and the portal vein to the liver. So we can see these branches. Let's talk about the liver lobule. What is it? It's we have present the hexagonal pattern of the lobes. So look, this is hexagonal pattern of lobe, and it has a central vein which runs through its center from the sinusoids. Yes, so this sinusoids, you can see here it. So the capillaries from the portal vein and plates of the hepatocytes. So look, these small cells, there are the liver cells, and they radiate toward an imaginary perimeter extrapolated from the surrounding interlobular portal triads. So look, here are present the interlobular portal triads, and in the center of the liver lobule there are present in the center the central vein. And of course around them there are liver cells, or they are called the hepatocytes. It will be also during the course of histology. So it was, okay, so I need to go faster. So interlobular portal triad was the branches, yes, the hepatic artery and the biliary duct. So let's go faster. So now let's collect bile from the liver, yes, because it's a very important function of the liver, production of bile. A bile, a yellow-green secretion for the passage to the descending part of duodenum. So hepatocytes, we can see such cells, they secrete a bile into the bile canaliculi. They are formed between the liver cells or hepatocytes. The canaliculi drain into the small interlobular biliary ducts, and then they collect the bile ducts of the intrahepatic portal triad. So interhepatic portal triads. So look, this bile canaliculi, interlobular biliary ducts, and the bile ducts of the intrahepatic portal triad, they form the intrahepatic biliary ducts. Such intralobular or interlobular bile ducts, they are called the cholangioles. And next, the bile ducts of the intrahepatic portal triad, they merges to form the right and left hepatic ducts, but these ducts are the extrahepatic. So this free one, yes, there are intrahepatic, and let's go to the extrahepatic. So the right and left hepatic duct is drain the right and left lobes of the liver, and the right and left hepatic ducts unite to form the common hepatic duct shortly after leaving the porta hepatis. Common hepatic duct is joined on the right side by the cystic duct to form the common bile duct. Sometimes in your book, in your atlases, you can find that this bile duct is called without this common. But when we add this common, we emphasize that this bile duct was formed by the common hepatic duct plus cystic duct. So this is common bile duct. And bile duct conveys the bile to the descending part of the duodenum and enters in the major duodenal papilla. Common common bile duct forms in the free edge of the lesser omentum, so it passes in the hepatoduodenal ligament. The length varies from the 5 to 15 centimeters. It depends on where the cystic duct joins the common hepatic duct. Common bile duct descends posterior to the first part of duodenum, lies in a groove on the posterior surface of the head of pancreas, and on the left side of the descending part of the duodenum comes into the contact with the main pancreatic duct. Hepatopancreatic ampulla, ampulla of water, which is more common use, so is formed by the union of the main pancreatic duct and the common bile duct. Is the dilation within the major duodenal papilla. The circular muscle around the distal end of the bile duct is thickened to form the sphincter of the bile duct. So, when the sphincter contracts, bile cannot enter the ampulla of duodenum. So bile backs up to the gallbladder for concentration and storage. So normally the bile is still produced. Yes, but when the sphincter is closed, yes, is in contracts, the bile should be removed, yes, to the gallbladder. And it happens in some diseases, yes, that there is present the jaundice, the icterus, yes. So it's a yellow staining of most body tissue. So look, is present the normal color of hand, and here is a jaundice, the icterus. So it's a yellow staining of most body tissue, the skin, the mucous membranes, the conjunctiva, by circulating bile pigments. It means that there is present the increased level of bilirubin. The jaundice is a result of liver or pancreatic diseases, the gallstones, which are present in the gallbladder, or also I need to add, because of my specialization, the hemolytic anemias, yes. So very often I need to differentiate, is present the hemolytic anemia, or there are simply gallstones, yes, some blockage in the bile ducts, yes. So sometimes it's difficult. The gallbladder lies in a gallbladder fossa on the visceral surface of the liver. It's a pear-shaped, has a capacity of up to 50 milliliters of bile. Has three parts: the fundus, which we can palpate, yes, the body, and the neck. Peritoneum completely surrounds the fundus and binds its body and neck to the liver. The fundus of gallbladder, it's a white end. It projects from the inferior border of the liver and is located at the tip of the right 9 costal cartilage in the mid-clavicular line. Here is present the mid-clavicular line, and this is the 9 costal cartilage, and here is the fundus of the gallbladder. Or we can say that the place of intersection of the right costal margin with the lateral border of the rectus abdominis muscle. It's normally 4-5 centimeters from the anterior median line to the right. The body of gallbladder contacts with the visceral surface of the liver, the transverse colon, the superior part of duodenum. So the body, yes. So sometimes there is present the green color of such organs. The neck of gallbladder makes a C-shaped band, joins the cystic duct. It's narrow, tapered, and directed toward the porta hepatis. The mucosa of the cystic duct spirals into a fold, the spiral valve, and keeps the cystic duct open. So, when the bile backs up, yes, so this cystic duct is open, yes, and the bile can rest here, yes, for the concentration in the gallbladder. Cystic duct is approximately 4 centimeters long. It connects the neck of the gallbladder to the common hepatic duct, passes between the layers of the lesser omentum. Usually is parallel to the common hepatic duct, which joins to form the common bile duct. Gallbladder is supplied by the cystic artery, and you will see it today from the right hepatic artery in the angle between the common hepatic duct and the cystic duct and the visceral surface of the liver. It is called the cystohepatic triangle or triangle of Callot. So it's between the common hepatic duct, cystic duct, and the visceral surface of the liver. So cystohepatic triangle of Callot. Here is present the cystic artery. The cystic veins enter the liver directly or drain through the portal vein. The veins from the fundus and the body pass directly into the visceral surface of the liver and drain into the hepatic sinusoids. Gallbladder is the innervation is by the nerves from the celiac plexus and from the right phrenic nerve. We remember that the right phrenic nerve, the branches, they can pass through the caval foramen, and the parasympathetic stimulation causes the contraction of the gallbladder and relaxation of the sphincters at the hepatopancreatic ampulla. So, after the big meal, yes, acts a parasympathetic innervation, so the gallbladder contracts, yes, and the bile can go through the cystic duct to the common bile duct, yes, and to the descending part of the duodenum for the digestion, yes, for the digestion, for the emulgation, because the bile is very important for the emulgation for the fat. Is stimulated also by the hormone, the cholecystokinin, which is produced by the duodenal wall in response to a fatty meal. And finally, let's talk about the spleen, yes, so this third organ about today we need to talk. But remember that spleen doesn't belong, yes, to the digestive tract, so the gastrointestinal tract. Spleen is the largest lymphatic organ. Why we talk today about it? Because at the next lecture we will talk about the kidney. Today we need to finish the gastrointestinal tract, and we know that the spleen is connected, yes, through the ligaments with the stomach, yes, by the gastro-splenic ligament. So we need to talk about it. Remember that it's the largest lymphatic organ. It participates in the, of course, the secondary lymphatic organ. Yes, it participates in the body's defense system as a site of the lymphocyte proliferation. Identify, removes, and destroys expanded red blood cells. Breaks down the platelets and is involved in recycling iron and globin. And also is blood reservoir, and it's very dangerous when the spleen ruptures during, for example, the car accidents, because sometimes it happens that it couldn't be fastly find such rupture of the spleen. And because the spleen is a blood reservoir, so it could lead to the death of patient. And it happens 10, 15 years ago. I remember some accident, a young girl, yes, a student, had a car accident in the Legionowa Street, and it wasn't recognized that her spleen ruptured, yes, and she died, yes. So it was very sad information, yes. So we need to remember that the spleen, yes, can rupture, yes, and there is a huge hemorrhage into the abdominal cavity. And of course, during some diseases, when we have the hemolytic anemias, or in the when we have the low level of the platelets, yes, sometimes we need to remove the spleen, yes, because it produces some antibodies, and they destroy the red blood cells and the platelets. So we need to remove the organ, and sometimes it helps. Yes, not in the all of patients, but in some of them it helps. Yes, that we remove the spleen, and we don't have some organs which produces the antibodies. So it's possible we can live without spleen, but sometimes we need to prepare a patient between the removing of the spleen. We need some injections against some bacteria. Spleen is approximately 12 centimeters long and 7 centimeters wide, and the thick is about the 5 centimeters. I need to remember such sizes of the spleen, because later the ultrasonographers, they write me the sizes of the spleen, the diameters, I'm sorry, not sizes, diameters of the spleen, so I need to know. It's a purplish color, it's the most vulnerable abdominal organ, and normally contains the large quantity of blood. The superior border of spleen is sharp and often notched, whereas the inferior is rounded. The spleen has a posterior, the medial end, and the anterior extremity. Or we can say that this is the posterior pole and anterior pole. Or end, more often end. Spleen is a mobile organ, is located intraperitoneally, and is located in the left hypochondriac region. is entirely surrounded by the peritoneum except a hilum. Spleen normally doesn't descend inferior to the left costal rib margin, but it happens in some hematological diseases that could be enlarged and can achieve the right iliac fossa, so it passes to the right side. So it happens, such enlarged spleen. Spleen rests on the left colic flexure, so the splenic flexure. There passes the phrenico-colic ligament. Spleen lies in the left hypochondriac region between the 9, now look, this is the back, yes, of the posterior surface, and the spleen is located between the 9 and 11 ribs, and is separated from them by the diaphragm and the left costodiaphragmatic recess. In the recumbent position, the long axis of the spleen roughly parallel to the long axis of the 10 rib. This is 12, 11, and 10. Hilum of the spleen is in contact with the tail of the pancreas, we can see it, yes, and constitutes the left boundary of the omental bursa. So it forms the bed for stomach. Anteriorly, spleen is related to the stomach. Now the stomach is removed for show us this surface of the spleen. Posteriorly, there is a diaphragm. Inferiorly, it's a left colic flexure with the phrenico-colic ligament. And medially, it's a left kidney. And remember that to the hilum of the spleen, sometimes the tail of the pancreas also is related to it. So, yeah, we can find on the spleen the gastric area, the renal area, colic area, and here the small one, the pancreatic area. The superior notch, the superior border, very often notch, inferior border, anterior end, and the posterior end, the medial end. Spleen is connected with the organs by the gastrosplenic ligament, so from the greater curvature of the stomach passes the ligament which connects the spleen. The splenorenal, so from the right kidney, splenorenal ligament which connects the spleen and the left kidney. These ligaments contain the splenic vessels and they attach to the hilum of the spleen on its medial aspect. And remember about this phrenico-colic ligament, which is not, normally it doesn't belong to the spleen, but it supports a spleen in a normal position, a correct position. Capsule of spleen is thin, composed of dense, irregular, fibroelastic connective tissue. It contains the smooth muscle cells. It's thickened at the hilum of spleen, and the trabeculae, which are present internally, they arise from the deep aspect of the capsule. They carry blood vessels to and from the soft parenchyma or the splenic pulp, yes, the substance of the spleen. The smooth muscle and the trabeculae periodically expel the blood into the circulation, so into the splenic vein. The splenic artery is the largest branch of the celiac trunk. It follows a tortuous course posterior to the omental bursa, so it forms also the bed of stomach. and anterior to the left kidney and along the superior border of the pancreas. Between the layers of the splenorenal ligament divides into the 5 or more branches that enter the hilum. Between the layers of gastrosplenic ligament divides into the short gastric arteries and the left gastroepiploic artery or gastroomental artery. And look, we can see it, yes? Left gastroepiploic gastroomental artery. And the short, the fundus of stomach. Splenic vein is formed by the several tributaries that emerge from the hilum. The splenic vein is joined by the inferior mesenteric vein, so this vein which collects blood from the 1/3 of transverse colon, descending colon, the sigmoid colon, and the superior part of rectum. And next, this inferior mesenteric vein is joined to the splenic vein. And this unites, the splenic vein unites with the superior mesenteric vein, and I hope you will remember, because I emphasized it that the junction, the union, is behind the neck of the pancreas. The superior mesenteric vein with the splenic vein, they form the portal vein. Splenic lymphatic vessels leave the splenic lymph nodes in the hilum and pass along the splenic vessels to form the pancreatico-splenic lymph nodes, which are around, they pass with the splenic artery. So they are located at the superior border because there is located the splenic artery, the superior border of the pancreas, of course. And the nerves, they derive from the celiac plexus. And thank you very much. So, okay, so maybe the 10 minutes for the break.
So the abdominal cavity, mainly alimentary tract, and it's grandiose as well as vessels supplying the abdominal cavity organs. There will be pictures coming from the computer tomography, as well as some radiological methods using barium and other radio contrasts. And this one comes from the computer CT, from CT, so computer tomography, and we have a transverse section at the level just below the diaphragm. There's a right and the left dome of diaphragm. So this is a cut through the inferior parts of both lungs and a heart. And at this level we can see that just anteriorly and a little to the left from the vertebral column we have a esophagus, and this is on thoracic part of esophagus and thoracic aorta. If we go a little inferior, we have a cut through the right dome of the diaphragm and the organ that lies just below the this part of diaphragm, which is a liver. So we have a right lobe of the liver here. Also, still the thoracic part of the esophagus. Below the left dome of the liver, at this level we can see a superior part of the spleen. Because the radio contrast was given intravenously, the blood at this picture can be seen as a much whiter. It fills inferior vena cava as well as the heart. And of course heart. If we go a little more inferior, we are moving in the direction. We can see cut through the liver and one of hepatic veins approaching the inferior vena cava here. So this is the one of the hepatic veins. Because it drains the blood from the right of the liver, this must be the right one. And running a little more inferior, you can see the whole transverse section through the spleen, as well as the abdominal part of esophagus, with the both crust of the diaphragm holding it at the both sides. So this is the part of the diaphragm, as well as this one. We can also see at this level the fundus of the stomach, the most superior located part of the stomach. The CT is not the only diagnostic method used to visualize the parts of the alimentary tract. For example, if we watch how the barium sulfate is swallowed by the patient, we can see how it moves down through the esophagus. And it fills esophagus, bringing us the information about its constrictions. For example, the thoracic and diaphragmatic constriction of the esophagus, so the second and the third one. As well as some disorders about the barium passing through the esophagus and stomach. Let's go back to the CT, and we have a little lower transverse section. We can see the whole stomach here, filled with the air, because this picture was taken in a patient who was lying on the table, so we can see the air filling the most superior located parts of the stomach here. So this is the air. We can also see almost whole liver, so we have a left and the right lobe of this picture, as well as two big vessels of the abdominal cavity. So this is the abdominal aorta and inferior vena cava. At this level, we can see more superior located left colic flexure. The right one will be much lower. And here's a left gastric artery approaching the lesser curvature of the stomach, as well as the second branch of the celiac trunk, which runs in the direction of the spleen, which is a splenic artery and the vein just next to it. The artery is much wider because it contains more radiocontrast, because it's arterial blood filling it. And once again, the parts of the diaphragm. So the right, yes. So the lumbar part of the diaphragm at this level, and the left one. And on this level, you can see how the celiac trunk branches into its two branches, because the left gastric artery was running a little more superior. We can see it, how it branched from the celiac trunk. But we can see a splenic artery and a common hepatic artery. After giving the gastroduodenal artery, it changes its name and approaches the hilum of the liver as a proper hepatic artery, or a hepatic artery proper. We can also see the superior part of the duodenum as a continuation of the stomach here. And of course, the body of pancreas. We are at the level of the between the L1, first and second lumbar vertebra, so we have a body of the pancreas here. It runs from the L1 or 2 level superiorly and to the left. In the direction of the spleen, you can also see a superior end of the left kidney here. We can divide the pancreas at this level into body and tail. As we examine the barium sulfate running through the stomach, we can see how its shape looks like, and also we can see how it passes through the rest part of the superior part of the alimentary tract. So here's a stomach, and there are 2 positions in which the picture were taken. So we have a supine at the left and upright on the left. At the supine on the right and at your right and upright on your left. And the parts of the stomach. Quite interesting is the fact that the stomach is really movable, so it runs about the height of the 2 lumbar vertebra when we change position from the supine to the upright. As well, the superior part of the duodenum also moves along the pylorus, so we can see it here. It moved inferiorly, but the fixed extraperitoneal part of the duodenum, of course, don't move. So we have a descending, inferior, and ascending part of the duodenum here. And this is the jejunum already. We can also give the radiocontrast directly into the bile ducts through the gastroduodenal ampule, cutting the sphincter of this structure and entering through the major duodenal papilla. And this diagnostic method is called endoscope retrograde cholangiopancreography. So this is a endoscope running through the esophagus, stomach, and the superior and descending part of the duodenum. And the radiocontrast was given into the bile duct as well as the main pancreatic duct. And that's why we can see it on this picture. So we have a main pancreatic duct, common bile duct, cystic duct, the gallbladder, and the common hepatic duct, branching into the right and the left hepatic duct. There is one thing abnormal on this picture. Can you see it? According to the gallbladder. Not whole gallbladder looks similar. As if you pay a little more attention to it, there are circular gallstones filling it. So we have a gallstones filling the gallbladder. First, second, you can count it. And the CT taken at the level of the gallbladder. So we have a superior mesenteric artery here. We have a head of pancreas, as well as the standing part of the duodenum surrounding it at its right. We can also see a gallbladder here. And the descending colon, transverse one. And on the next picture, we will find also the right coliflexure. So it's much more inferior. than the left one. It corresponds with the 8th rib, and the left one corresponds with the 7th rib. As you can also notice, the flexure, the right one, is located much more anterior than the left one, which was at this level. And here's also an inferior part of the duodenum. At this level, we can also see the artery and the vein, renal arteries and veins, running into the direction of each kidney. And at this level, at the level of the inferior part of the duodenum crossed, we can see how it's crossed by the superior mesenteric vein and artery. We can also see that the superior mesenteric artery sends the first jejunal artery here, in the direction of jejunum. A little lower, and we can see the small intestine coils filled with fluid. Also, we can see the ascending colon and the inferior mesenteric artery. So we are, it's branching from the anterior aspect of the abdominal artery. So we are around the level of 4th lumbar vertebra. Around the level of the 4th lumbar vertebra, there is a bifurcation of the aorta. This is about the 4 to 5 centimeters superior to this level. And then the standing colon. This is the cecum, and those are veins and arteries approaching it. So this is the iliocolic artery. At this level, the abdominal aorta already branched into the common iliac arteries. So we have a left and the right one here. And this is the inferior vena cava, which branches around the one below the branching of the aorta, around one high of lumbar vertebra below. And this is the left common iliac vein. You can see how the inferior vena cava branching into those two, left and the right one. We can also give some radio contrast through the inferior part of the alimentary tract through the rectum, and we can feel almost whole large intestine. This examination shows us how the large intestine behave, how it moves. Also, we can find if there are any abnormalities according to its wall. So we have a haustra here. This is a physiology, so there is no pathology here. We can see almost all parts of the large intestine as well as ileum. So this is the ileum, the cecum. This narrow part corresponds with the ileocecal valve. And we have a ascending, transverse, descending sigmoid colon as well as rectum. You can see the differences between the localization of the right and the left colic flexure. The left colic flexure is also much sharper than the right. And this is the section through the sagittal plane. We can see the vertebral column, of course, as well as the abdominal aorta here, branching into its first and second unpaired visceral branch, which is a celiac trunk and a superior mesenteric artery. And the celiac trunk at this level also sends the left gastric artery here. You can also see a pancreas, left lobe of the liver, pyloric antrum filled with air, as well as the transverse column, a little more inferior to it. We can also see sigmoid column. It would be at this level would be a sacral fracture of the rectum already. And if we move a little to the right, we have a transection through the hilum of the liver, as well as the right kidney. So we have some structure that the hilum or the porta of the liver, porta hepatis, contain. So we have a common hepatic artery. At this level would be rather the proper hepatic artery already, and we have a proper hepatic artery, common hepatic duct, and a little more posterior to those two structures there is a portal vein. So those three structures are abandoned with a hepatoduodenal ligament. And those are small intestine coils. We can also produce some 3D images of the arteries filled with the blood containing the radio contrast. And this is the abdominal aorta filled with the radio contrast, which allows us to produce such visualization. And this is the first visceral branch of it. So this is the celiac trunk, giving the left gastric artery and the splenic artery, running with the curved one here, and also the common hepatic artery, which sends gastroduodenal artery here and the right gastric artery here. Gastroduodenal artery. Of course, after sending gastroduodenal artery, it changes its name into proper hepatic artery. And we have also superior mesenteric artery and the paired renal arteries. So this is the right. The left one is here. We can also find, as I said before, about 4 to 5 centimeters above the bifurcation of the aorta, there is an inferior mesenteric. Speaking about the superior mesenteric artery, it also branches into some arteries, which we can find here. So we have jejunal arteries, right colic artery, and its terminal branch, the ileocolic artery. We can also see the two terminal branches of the abdominal aorta, which are the common iliac arteries, here and here, and those branch into the internal and external iliac arteries. If we pay a little more attention to, for the inferior mesenteric artery, you can find that it also sends colic artery, this time it's left one, running like this. The second one would be one of the sigmoid arteries, and the terminal unpaired branch is it runs here, and it's a superior rectal artery. And that's all I wanted to show you. Okay, so let's find out how much you remembered.